Thank you, Dr. Merki. So welcome everyone to session 4. I'm going to cheat with a note on my phone because it's very difficult. So it's an honor to welcome Dr. Hisham Lakhal, Mohammed Hisham Lakhal, among us at the Congress today. So I'm pretty sure I can call you doctor since you have presented your thesis. Is it okay for everyone if I call him doctor? Okay, fine. So Dr. Lakhal is a former and very influential member of GEMT, and I think he's one of the most respected young Tunisian psychiatrists, and he's here to tell us a little bit more about functional neuromarkers in psychiatry. So please, Dr. Lakhal, we'll not keep you waiting any longer.
Hello, everybody. Thank you, Jihad, for your presentation. It was very funny. I'm very glad to be here today among you, back to my future. And I want to thank the Tunisian Bipolar Forum and Jeune Psy for giving me the occasion today to talk about, to make a little introduction about functional neuromarkers in psychiatry. So, but first of all, I'm gonna start my talk about cardiology. This is a cardiologist. And in an emergency setting, he received a patient with chest pain symptoms. He performed an electrocardiogram, which was recording the heart's electrical conduction system. So, how does an ECG work? So, an ECG picks up electrical impulses generated by the polarization and depolarization of cardiac tissue in the form of specific waves, giving informations about rate and regularity of heartbeats, size and position of the chambers, presence of any damage in the heart, and may provide a clue as to whether a patient is having an ischemic event. However, a psychiatrist seeing a patient with schizophrenia symptoms wouldn't ask for an EEG recording and assessment at a first choice. This is despite the fact that an EEG could tell us much about the course of the symptoms in theory. So, why do we use recording of electrical signals for diagnosis in heart disease, but do not use recording of electrical signals in psychiatry? So the brain is much complex than the heart, and heart physiology provides a relatively limited number of ECG parameters that can be used for diagnosis and which are easily identified and whose waveform have clinical, functional, clear meaning in the heart cycle. In contrast, the number of parameters provided by multi-channel EEG and resting scale is enormous. And if we add the event-related potentials in the analysis, the amount and quality of information will increase tremendously. A heart is a relatively simple organ of the body, whereas brain is the most sophisticated system in the world, intended not only to self-regulate, but also to process external and internal information unconsciously and consciously. And the cardiologist you saw could rely on well-established theory of the heart in his clinical practice. In the meantime, there is no theory of brain functioning so far. So, ECG waveforms do not show big intra-individual differences and have clear diagnostic value. In contrast, EEG and especially ERPs show large inter-individual variations. So, similar reasons may explain why other functional neuromarkers such as magnetoencephalography, MEG, functional magnetic resonance imaging, fMRI, and positron emission tomography, PET, have not been used in clinical practice so far. obvious place was found for imaging in many areas of the surgical and medical field interventions. So a surgeon may confirm the successful treatment of a fractured bone by a follow-up X-ray, whereas an oncologist may check whether a chemotherapy of metastatic cancer has been successful only with an FDG PET scan. Psychiatric treatments do not directly target identifiable organic pathology, so there is not such a role for imaging and clinical treatment validation in psychiatry presently. However, research into the use of neuroimaging for the detection and monitoring of treatment effect has greatly expanded over the last decade, and first studies have explored whether imaging parameters can predict who will respond to what type of treatment and thus aid patient stratification. And finally, neuroimaging already has a place in the design and monitoring of brain modulation treatments. So let's go through some history. Diagnostic categories of mental illness described in DSM are not organized according to impairment in brain systems, and those categories were formulated 100 years ago by a small number of psychiatrists such as Bleuler and Jaspers, who relied only on similarities in behavioral syndromes and clinical outcomes of patients they encountered, which makes the category reflect only observable behavior rather than dysfunction in distinct anatomical physiological substrates. So, till the 90s, we began discovering new methods and accumulating data. That was the decade of the brain. And since 2000, we began searching for neuromarkers and testing neuromodulation techniques. That was the decade of discovery. And now, we are trying to use neuromarker for personalized care and prevention of diseases, and that is the decade of translation we are in. So, what is a biomarker? A biomarker is a characteristic that can be objectively measured and evaluated as an indicator of normal biological processes, pathogenetic processes, or pharmacological responses to therapeutic intervention. There are many kinds of CNS biomarkers for CNS disorders such as clinical, neuroimaging, biochemical, genetic, and proteomic markers. An ideal marker should be sensitive, should be specific, should be reliable, reproducible, and should be confirmed at least by 2 independent studies. The neuromarker respond to a narrower definition than biomarker and include objective measures of brain anatomy and physiology obtained in clinical practice using neuroscience methods, including neuroimaging with MRI, fMRI, PET, and measuring parameters of EEG and MEG, such as quantitative EEG, key EEG, and event-related potentials. This term was first introduced by Evan Gordon from the University of Sydney in 2007, including any neuropsychological parameter of behavior and any structural or functional index of the brain. So, we know that similar symptoms may be induced by a local damage in different part of given widely distributed neuronal circuit of the brain. And this statement has been supported by many studies of functional brain activity such as ERP, fMRI, PET recorded under various psychiatric conditions in comparison with healthy controls. So we are going through some examples. First of all, from neuroimaging. The first use I've chosen to talk about is the side effects, whose mechanisms were poorly understood, so it was hard to design safer alternatives. We know, for example, that extrapyramidal side effects of antipsychotic drugs may be due to high occupancy levels of dopamine receptors, while sedative effect may be due to anticholinergic or antihistaminergic effects. There is one example of a common side effects with unknown mechanism, which is sexual dysfunction on treatment with antidepressants the example of SSRI. So patients who had developed sexual dysfunction on treatment with SSRI showed lower activation of areas in the midbrain and frontal lobe when exposed to erotic video clips than patients on placebo or bupropion. And this makes an indirect evidence for a dopamine-related mechanism for SSRI-related sexual dysfunction, because a similar attenuation of reward responses has been observed after administration of antipsychotic drugs. So, the second example is the treatment response prediction. So, as we know in the clinical field, only a minority of people with mental disorder respond to the first medication, and we usually try several antidepressants or antipsychotics before we find the medication that can suit our patients. So it's very difficult to predict from clinical parameters alone whether a patient will respond better to a primarily serotoninergic or noradrenergic antidepressant, for example. So I will take the example of neuroimaging treatment selection biomarker for major depressive disorder. So to guide antidepressant treatment selection, a clinically meaningful and treatment-specific biomarker should first of all predict an individual's improvement to a specific treatment, and second, predict also non-response to an alternative treatment. And that's why we had the need for a study assessing the association of pre-treatment brain activity patterns with differential response to different treatment, for example, medication versus psychotherapy. And this was done by the study of McGrath in 2013. It was a 12-week randomized study of CBT versus medication treatment for MDD, identifying 6 pattern subtypes of FDG PET. The anterior insula was the region of the brain which best described the treatment outcome. So the anterior insula hypometabolism was linked to remission to CBT and to poor response to escitalopram, whereas the hypometabolism of the same region was linked to remission to escitalopram and poor response to CBT. So we can say that insular metabolism alone may serve as a pre-treatment biomarker to guide initial treatment selection, and that could be a potential candidate for imaging treatment-specific biomarker. So the second example is the prediction of the response in social anxiety disorder from fMRI. So Durman in 2012 conducted the first study to apply neuroimaging-based treatment response prediction to patients with SAD. And they conclude that pre-treatment brain responses for angry versus neutral phases in 2 occipitotemporal brain regions were positively and significantly linked with CBT outcome. So the neuroimaging measures, in combination with treatment severity scores with Leibovitz scores for social anxiety disorders, predicted CBT outcome significantly better, accounting for about 40% of the variance in treatment response than prediction based on Leibovitz alone, which accounted for 12% of the variance in treatment response. So treatment prediction that additionally included neuromarker substantially outperformed predictions based only on clinical measures. So the finding that functional brain responses to faces angry versus neutral, but not scenes, negative versus neutral, predicted treatment despite the equating of face and scenes for emotional balance and arousal, which is consistent with the specifically social basis of the disease. So we can conclude that neuroimaging may offer an evidence-based path towards selection of optimal treatments, that Neuromarker could selectively identify which patients are more likely to benefit from which treatment option, and we may go through an integration of neuromarker with genetic, behavioral, and other biomarker in order to refine the prediction for individual patients. We are going to now see some examples from neurophysiology, starting from schizophrenia. So, in the beginning of the 20th century, Bleuler considered sensory processing to be intact in schizophrenia. And psychological studies in the 60s documented sensory distortion spontaneously reported by individuals experiencing early symptoms of schizophrenia, and subsequent electrophysiological studies objectively demonstrated neuronal correlates of sensory deficits. So, with the accumulated knowledge since today, Bleuler was finally wrong. So, I will speak about a sensory-related neuromarker, which is one of the most robust sensory-related neuromarkers in schizophrenia, the P50 gating failure. So the P50 is a mid-latency cortical response to a brief auditory stimulus. So I will explain this a little bit. So in studying the P50 wave, 2 clicks of 70 decibels are used apart. Usually, the response to the second click is reduced in the amplitude, as you see here, and as you see here, in comparison to the response to the first click. This is considered to be an electrophysiological signature of sensory gating. So in some persons of schizophrenia, the amplitude of response to the second click is not reduced, and this is interpreted as a failure of sensory gating. As you see, it is not reduced. So, the P50 gating effect is enhanced by nicotinic cholinergic mechanism, indicating that smoking in schizophrenia may be a kind of self-medication for patients. So, an abnormality of the P50 auditory evoked potentials is considered as an endophenotype of schizophrenia. So, the second example is the mismatch negativity, which is the most successful among the proposed electrophysiological indices of schizophrenia, and which is a component of the auditory event-related potentials occurring around 200 milliseconds after a deviant stimulus that differs from a series of repetitive stimuli in duration, pitch, intensity, or locus of origin. So it will have been shown that MMN was reduced in patients with schizophrenia compared to controls, but also in people at genetic risk. This parameter was also used for predicting conversion to psychosis in clinically at-risk mental scales individuals. And the MMN is followed by P3A, which is a component of the well-known P300. And it has been proved the reduction of MMN and P3A in schizophrenia, as you see here, the P3A and the MMN. And this was shown by many studies. So the P3A and the MMN have qualities of endophenotypes, including heritability, test-retest reliability, and trait-like stability. Another example is the example of the object recognition deficits. The N170 and N250 are ERP waves associated with familiar object processing and especially face processing. In 2040, studies reported that these two waves were suppressed in schizophrenia, reflecting the well-established behavioral deficit in face emotion processing in schizophrenia patients. So you can note here that the extracted N170 component is generated in the fusiform gyrus, which is an area in the ventral visual stream known to be involved in the face recognition and whose damage may lead to misidentification syndrome such as Capgras syndrome. We talked about the P3A. The other component of the P300 is the P3B, which has been found to be the best predictor of subsequent psychosis in a group of subjects at ultra-high risk for developing psychosis. Converter versus non-converters. The last example in schizophrenia is the example of the hyperfrontality, which is a predictor of response to medication. For that, we use go, no-go for differentiating the group of patients with schizophrenia versus healthy controls, and also to predict response to medication. So differences between electrical and metabolic activation in go and no-go conditions were smaller in schizophrenia. And there is a parameter, no-go anteriorization, NGA, which reflected the cognitive control and was significantly reduced in patients with schizophrenia. So it has been shown that a high level of NGA was linked to a better response to typical antipsychotics, whereas a lower level of NGA, which is in the same time an index of hypofrontality, was linked to a better response to atypical antipsychotics, which affects more frontal lobe function. So we can say that NGA is a predictor of our treatment response to first and second generation antipsychotics. I will take now the example of HAD. As you see, it's a multifactorial disease. I'm not gonna go through details, but I will only speak about some fMRI correlates. They discovered a reduced right globus pallidus and putamen volumes in ADHD patients with decreased caudate volumes and frontostriatoparietal dysfunction during tasks of inhibition and attention. So several subtypes of key EEG patterns in ADHD have been individualized also, and there have been many distinct EEG-defined cluster endophenotypes. And finally, the N200 wave in response to stop signals was markedly reduced in ADHD and significantly correlated with response treatment inhibition performance. So, event-related potentials are predictors to response to psychostimulants. So a dysfunction in the frontal circuits in an individual with ADHD may predict a positive response to psychostimulants versus selective dysfunction in parietal circuits, which predicts a higher probability of being non-responder to psychostimulants. So today it's about future. We'll try to make a little flash forward. So this is what's gonna be like in the future. In contrast with the 20th century psychiatrist whose working space was a room with 2 armchairs, the working space of the 21st century psychiatrist may look like this. The psychiatrists order the assessment of functional neuromarker, which includes recording of an EEG of a patient under resting state and task conditions. Subsequently, there is processing the data, then comparing the results of processing with the reference database, and then compiling the report. And the report is made by an expert, is further sent to psychiatrists, who used it for making decisions about individual treatment. And the arsenal of the 21st psychiatrist could look like this. So, happily for most of you, my talk finally comes to an end. And for the take-home message of this lecture, I've chosen to talk about an old car. So, this old car failed to start. That could be due to a damage in spark plugs, to a damage in battery cables or gas distributing system. So as you see, number of different automobile mechanisms might lead to similarly perceived symptoms. So what to do then? It is difficult to distinguish which mechanisms are dysfunctional to fix them without the ability to look under the hood of the car. So by analogy, finding a neuromarker of a disease allows us to look under the hood of the mind and to discover which mechanisms may be dysfunctional for a given disorder in order to optimize the treatment. And when it comes to cars, you may exchange your new car by your old car by a new and more beautiful one. By analogy, well, let's say until the success of the first head transplant surgery, for which psychological effects are not guaranteed, we will have to keep dealing with our old dysfunctional brains. And thank you for attention.
Thank you. We have some questions.
Thank you very much for that very comprehensive, very interesting, and very thought-provoking presentation. I think that it's wonderful that you're starting to talk about the use of neuromarkers for prediction of treatment response, outcomes, and so forth. So I think that we are headed for that in the future. The data and the studies that you showed were very compelling, but what they do is they present information on group effects. And I think the issue is that when it comes to the individual, we have findings like in schizophrenia, for example, you mentioned P50.